So good afternoon, everyone. I think that's afternoon, everyone. And we're ready to start. So welcome to this BLS session. My name is Teresa Olasvängen. I'm one of two ERC co-chairs for Basic Life Support Science and Education Committee. And I will be chairing this session together with James Nicholson. James, I'll let you introduce yourself.
Hello, good afternoon. My name is James Nicholson. I'm a medical student in Leeds and I'm the Young ERC's student rep.
Perfect. Okay, so we'll be trying out some polls. We'll be taking some questions. Our plan for today is we have 3 speakers. We'll be taking your questions after each talk. James will be looking at those questions, and we'll also be testing some polls as we go. So to get us all started, we have Artem Kozlovlev. He's the head of the Nagovsky Institute and an intensivist from Moscow. He's speaking to us on high quality CPR. Go ahead, Artem.
Thank you so much. Okay, good afternoon, dear colleagues. I'll try to put on my presentation, and my topic is really the quality of chest compressions, and it's one of the key issues within our BLS session, I think. I have no conflicts of interests to disclose, and I want to start with this slide because I think, and I'm sure that we all, in all our countries and in our resuscitation world, we stand on the shoulders of giants. And for the resuscitation world, Nagovsky and Peter Safar are those 2 giants. And I'm very honored to make this presentation on this ESC Congress 2021 and to run this presentation from the Nagovsky Research Institute in Moscow. I'm very much sure that the current guidelines are also inspired by the scientific background of these 2 people. So we all know that chest compressions are the key element of the chain of survival, and definitely start chest compressions. That's the key of the BLS algorithm, to start chest compressions. That's the key of the BLS algorithm. Officially, this is one of the first publications in JAMA when closed chest cardiac massage chest compressions were first described. And now we know, and it is reflected in the guidelines, that it is not only important to run chest compressions, it is also very important that these chest compressions are of certain quality. And the third thing is that they should be as continuous as possible. So what are the determinants of the high quality chest compressions, which is very important, not only for return of spontaneous circulation, but also for the better neurological outcomes? It's the hand position, lower half of the sternum. If you are the instructor, you describe it like in the center of the chest. Depth from 5 to 6 centimeters, rate from 100 to 120, as few interruptions as possible, complete chest recoil and no leaning, and it is recommended to run chest compressions on a firm surface whenever possible. So why is it also so much important? Because when we compress the chest, we perform some perfusion, and primarily we think about the coronary perfusion pressure, which is related to the ROSC, which is reflected in some experimental and clinical data. So effective chest compressions mean perfusion, and it is related to the ROSC and better neurological outcomes. And it is also very important that chest compressions must be continuous, because when we stop, there is no perfusion and we have worse outcomes. So I can't say that we have much more additional evidence at the international level to this question of the quality of chest compressions, because the bad thing is that we don't have enough big studies with exact endpoints, with endpoints of ROSC or neurological outcomes. So not many wordings in the guidelines may be changed, But the main idea is the following, that if we talk about the quality of chest compressions, first of all, there is the question of the hand position. And there were lots of studies about the hand position, lots of imaging studies which were not taken into the account at the ILCO level. And the guidelines, in the guidelines, we see that hands should be positioned on the lower half of the sternum, in the center of the chest. It is reflected in ILCO guidelines, performing chest compressions on the lower half of the sternum in adults in cardiac arrest, and it is weak recommendation with very low certainty of evidence. And in the ESC guidelines 2021, we see that it is recommended to teach that chest compressions should be delivered in the center of the chest, demonstrating hand position on the lower half of the sternum. So that's about the hand position. The complex issue about rate, depth, chest wall recoil and leaning, it was a scoping review published in Resuscitation, and really it is noted that significant gaps in the research evidence related to interactions between chest compression components. So the majority of studies, they're very separated. Each study investigates either in rate or in depth or in chest wall recoil. It is quite difficult to analyze the interaction between these three parameters. So no sufficient new evidence that would justify conducting a new systematic review or reconsideration of current resuscitation treatment recommendations. That's what is stated in this scoping review. So what is high quality chest compressions? About depth, it is not more than at least 5 centimeters and no more than 6 centimeters. If it is lower than 5 centimeters, it's not effective. If it is more than 6 centimeters, it is more traumatic, more damaging. Talking about the rate, it is between 100 and 120 with as few interruptions as possible. Complete chest recoil with no leaning is also very important because it determines the backflow of the blood into the chest, into the heart. And about the surface, it is recommended. We have many studies, clinical and mannequin studies about this issue, about the surface on which we perform CPR. But in the ESC guidelines, it is recommended that for the in-hospital settings, in general, we have to run CPR on firm surface whenever possible. But for the in-hospital setting, it is not recommended to move patient from the bed to the floor because it's a special skill and you waste time doing it. It may damage the patient. And the ESC does not recommend using a backboard because there is not much additional data and solid data on using a backboard during CPR. So also a short note about using audiovisual feedback and feedback devices, because it was a huge discussion about it. It is also reflected in the educational part of the guidelines. The current evidence shows that they may be used, this CPR monitoring, only within the healthcare system to improve key CPR metrics within the system in general. And there are no data that using audio-visual feedback devices and prompt devices during the real time CPR in rescuers that it affects somehow the survival. So it is not recommended at all. And also in the guidelines, it is reflected the issue of these alternative compression techniques. We all know that there are lots and lots of these alternative compression techniques, Corv CPR, Recoil thumb, fist pacing for cardiac arrest, and in general, it is not recommended. It is recommended against using these techniques, excluding some special situations which are written in the guidelines in more detail. So, finalizing my presentation about the quality of chest compressions. So chest compressions are the key element of the BLS algorithm. We have to start chest compressions as early as possible. We have to pay attention to the quality of chest compressions. It is hand position in the center of the chest, lower half of the sternum, depth, rate, complete chest recoil, and as few interruptions as possible. Thank you so much.
Thank you so much, Artem. I think we're just going to head straight over to James to see if we have any good questions from the audience.
Yeah, so to start with, we've got another poll, hopefully quite a simple poll to start with that's just gone live. So do take a look at that. Artem, there's a couple of questions I've picked out from the audience to ask. And if anyone has any other questions for Artem, please do post them while we're talking. So you mentioned a firm surface and that the guidelines don't recommend moving someone to the floor in hospital. There were quite a lot of questions coming through about what happens out of hospital and also what constitutes a firm surface in this context.
Yeah, that's a good question. So I think that it is written in the guidelines that whenever possible, the chest compressions should be run on the firm surface. So I think there is no exact definition of the firm surface in the guidelines, and if it's possible, I'm not sure whether it's possible to define it or not. But I think that that's the issue of every guidelines. That guidelines give some general idea and the direction based on the evidence, and it cannot be applied in any situation. And it is especially much more difficult for the out-hospital situations when there may be a variety of surfaces. So maybe Teresa, you can add anything else, but I don't know any more evidence on this.
No, I think, as you said, it was a difficult question and heavily debated. And I think it's, I guess, to a certain extent, a common sense issue as well. And with the change in guidelines, wanting to reflect that it's not, getting the person on the floor at any cost, because there is a certain amount of risk associated with trying to move a patient or even trying to place the backboard as well. So I think that's what the guidelines are trying to reflect, is balancing those risks against each other. And I think at the end of the day, it's always going to have to be a judgment call from the rescuers on site. I agree with you, Artem.
So there's another couple of questions that relate to the depth of CPR. So a lot of people have asked 5 to 6 centimeters is quite specific. Should we do anything differently in more overweight patients, for example, or how transferable is that into people when they're doing CPR actually being able to know, because 5 to 6 centimeters is quite difficult to measure when you're doing CPR?
So as I understand, that's the idea of simulation medicine under it, as I understand, because you will never compress the chest exactly 5 to 6 centimeters if you are not trained. And the idea of BLS training is that you gain some skill of this 5 to 6 centimeters, and then without any audio-visual feedback, we hope that you transfer this skill to the real life CPR. And the 5 to 6 centimeters, it is transferred out of the studies, and definitely it is applicable to some average sized people. We're talking about age and weight, and definitely if you have a very thin person or very overweight person, maybe we can't apply this 5 to 6 centimeters. And it is not in the BLS chapter, but I'm sure, maybe you correct me, it is in special circumstances. And sometimes I remember it was in the BLS manual that we teach that it is 5 to 6 centimeters or 1/3 of the anterior posterior size of the chest. That's maybe the most universal explanation for that.
And another question on this topic, one that's quite important to clarify. Obviously, there's a big focus at the moment on high quality chest compressions, but just to be clear, is mouth-to-mouth or rescue breaths still in the BLS guidelines?
They are still in the BLS guidelines, definitely taking into account all the infectious issues and infection issues and COVID-19 issues, but we all know that resuscitation without ventilation will be maybe less effective, and we can run compression only CPR, but just in some special circumstances when we are untrained or when we think that there are some risks to the rescuers.
Brilliant, thank you, Artem. I think there's some other questions that we'll come back to a bit later on if we've got some time. Just the poll that we started with there, quite a simple one, but hopefully most people got correct that all three of those elements are critical to high quality chest compressions.
Thank you.
Perfect. Thank you, guys. We'll see if we have time to get back to some additional questions at the end. But now I think we'll move along. We have Giuseppe Restagno, anesthesiologist and CPR researcher from Milan. He'll be speaking to us about bystander CPR and the use of Aed.
Thank you, Teresa, and good afternoon to everyone. Okay. Okay, so now we continue with bystander CPR and the use of Aeds. These are my conflict of interest. So we saw that the 5 top messages for BLS 2021 are those here. So we need to recognize cardiac arrest and start CPR. We need to alert the EMS, and then we need to start chest compression and get an Aed as soon as possible. And of course, we have to know how to do all these procedures and how to perform CPR. When we talk about bystander CPR and Aed, we are, of course, focusing on the first 3 rings of the chain of survival, which are the most important rings accounting for outcome. Indeed, we know that immediate bystander CPR can double or triple survival of cardiac arrest. And if we are able to perform an early defibrillation within 3 to 5 minutes, survival can rise up to 50 or 70%. Of course, this is possible only with implemented public access programs and with on-site Aeds. Some years ago, Charles Dickens remodeled the chain of survival in this way, just to highlight the importance of early recognition by bystander for recognition of cardiac arrest and the early start of CPR, because these 2 initial managements are the most important procedures impacting on survival. So how we can recognize cardiac arrest? The new guidelines tell us that we need to suspect cardiac arrest and start CPR when the victim is unresponsive and has absent or abnormal breathing. Of course, with only these 2 aspects, we risk to over-triage cardiac arrest, but on the other side, this risk overweight the real risk to delay CPR in the instance of a cardiac arrest. And then the new guidance also focus on 2 important signs that sometimes can lead to misinterpretation and delay in the recognition of cardiac arrest, which are the agonal breathing and the seizure-like movements. So agonal breathing is frequent. It can occur in almost half of cardiac arrest victims. And sometimes it is difficult for the dispatcher to see and to recognize if it is a breathing or a normal breathing. In fact, in these studies from 2018, you can see when the dispatcher asked to the caller if the victim was breathing, you can see that there is various different answers. So gasping can be presented as gasping or groaning, moaning, labor breathing. Sometimes the answer, I don't know. So of course, all this can delay recognition of cardiac arrest. Similarly, the presence of seizure, which can be present in approximately 4% of the cardiac arrest. You can see here in this nice picture how seizures can delay the different intervention to recognize cardiac arrest. and can be a delay of more than 40 or 50 seconds sometimes. So after with the first suspect a cardiac arrest, we need to alert immediately the EMS. If there is a single rescuer with a phone, it should activate the speaker or other hands-free options while starting CPR, so it can call the dispatch and start CPR simultaneously. If in the instance the single rescuer is without a phone, then it can leave the victim to alert the EMS first, and then you go back to start CPR. This is an important point because there was a lot of discussion of CPR first or CAL first. This is a study of more than 40,000 bystander cardiac arrests, in which results of 3 different strategies were investigated. So an immediate call plus CPR, or call first, or CPR first. As you can see, there was no difference in neurological favorable survival with the 3 different approaches, although then some sub-analysis show that CPR first strategy is better. Nevertheless, this study was performed in 2015, so before the widespread of smartphone. Today, with smartphone, it's possible to activate the speaker, and so to call the EMS and starting CPR concurrently. And this is what the ERC guidelines recommend. So then we recognize cardiac arrest, we call the EMS, we start good quality CPR as we learned from the previous presentation, and then we need to get an AED as soon as possible. AEDs can save lives because they can make possible for lay people to attempt defibrillation minutes before the EMS arrival. They can detect the heart rhythms, and if it's shockable, they can guide with audio or audiovisual prompt the operator to deliver the shock, and then they will follow the rescue step by step for all the other CPR interventions. We know that survival decrease for each minute of delay of defibrillation of approximately 3 to 5%. And for this, it is important to get an AED as soon as possible. And let's see what the guidelines say, what is the algorithm when we receive CPR, when we receive an AED. So we are performing CPR. As soon as an AED arrives, we switch it on, and then we attach the electrode pads according to the position shown in either in the AEDs or in the pads. And then if more than one rescuer is present, one will continue with CPR while the other will attach the pads. Then we just need to follow the audiovisual prompt. And we need to be sure that no one is touching the patient while the AED is analyzing, and then prior to deliver the shock. Then after the shock, we restart immediately CPR, and the AED will tell us when the next rhythm analysis should be performed, so every 2 minutes. In this slide, I highlight this concept of continuous CPR while pads are being attached. Why this? Because in 2020, ILCOR performed a systematic review analyzing approach with in which an interval of CPR was performed prior to deliver the shock compared to shock first. 5 studies were included in this meta-analysis, and no effect on either important and critical outcome were observed. So for this, ERC recommends CPR to be continued until an AED arrives, switch on, and attach it to the victim. But then the defibrillation should not be delayed for any other additional CPR intervals. We know that the use of AEDs by bystander is safe. There are thousands of publications now. And of course, the location AED should be clearly indicated. This is a meta-analysis showing the use of AED by bystander and reporting a clear beneficial effect on neurological outcome and survival both for shockable rhythm and for non-shockable rhythms. And this is one of the last studies in Japan, published in the Lancet in 2019. More than 1 million and almost 3,000 patients. You can see that with the PAD program, neurological outcome and survival was significantly better compared to no PAD programs. And indeed, the use of Aed decreased the time for delivery of first shock from 12 minutes compared to 1 minute. And the beneficial effect of the of a PAD program was present and was even more clear when the response time by EMS was prolonged. Today, we saw also in the guidelines that the role of technology is highlighted, and technology is really important also to communicate with bystander and to deliver an Aed on site. In fact, retrieving an Aed sometimes can be challenging during an emergency situation, but now we have the app that can help in locating and showing the nearest Aed, or also to display the route to reach an Aed. And also they are important for creating registries or for maintenance of the Aeds. Indeed, now there are many studies that have been published. This study on the top show that thanks to the use of mobile phones to retrieve Aed, when more than 2 Aed were present per kilometers and when more than 10 bystander responses were alerted, the probability to deliver a shock prior to the EMS arrival was increased a lot. And the study below instead is meta-analysis of 12 different systems adopting different mobile phone approach to locate the Aeds. And in all the cases, there was a significant impact in increasing the rate of bystander CPR and also in survival. So this approach now is present in both the BLS chapter and the System Cell Life chapter of the new guidelines. Of course, when we talk about bystander CPR and the use of Aed, it is a complex systems. We need to train people. We need to have a PAD programs on site, and we need to also locate the Aeds. And all these aspects are really important. This is a study in Singapore where they reported the 4 years of implementation with different step approach. Before they created a standardized protocol for dispatch, then they introduced the telephone assisted CPR. In another period, they introduced telephone assisted CPR plus CPR training program in all the cities. And then finally, in the last period, they also introduced an app to deliver the Aed and deliver the bystander rescue to the cardiac arrest victims. As you can see, each step was crucial to improve the probability to receive bystander CPR, and then this was reflected also in a continuous improvement in survival to hospital discharge. So all these aspects are really important, together with, of course, training and public awareness. And in this ERC has put in a lot of effort in the last years with the European Restart Heart Day first, and now the World Restart Heart Day. Thank you very much for the attention.
Thank you so much, Giuseppe. So now I suspect James has launched a new poll for you guys to have a look at. And I don't know, James, do we have any good questions lined up for Giuseppe?
Yeah, we've got loads of questions coming through. To start with, we've launched a second poll, and this is, what do you think is the biggest barrier to bystanders starting BLS? So have a look at that while we do the questions. So there's lots of questions coming through about CPR monitoring, about BLS in the context of COVID-19, and also the first questions about whether we should call first or whether we should compress first. And I know that's a contentious topic. So Giuseppe, in terms of, should we start CPR first or should we call for help first?
Okay, well, as I showed before, actually the compression first approach seems to be better, but now widespread mobile phone and the smartphone, actually the recommended approach is to turn on the speaker or other hands-free option in mobile phone, and so call the EMS while you start CPR. So performing the two approach concurrently. Now this is possible with everyone of us has a mobile phone now on his pocket.
Okay, and some more questions about CPR monitoring. So if I've understood correctly, there's a recommendation that CPR monitoring can be used in training, but there's no recommendation that it should be used
yes. So regarding the feedback systems, all the literature show that when we use a feedback system, we can improve CPR metrics. However, there are no clear effect on outcome. So basically, current recommendation is to use feedback devices, but in a whole in a process of quality implementation of the system, not as a single intervention.
So it's to do with there being a lack of evidence.
Yes.
Yeah. Thank you. There's a few questions coming up about COVID-19 and BLS, and I know there's separate ERC guidance on that, but there's one question which is, do you think we'll have more guidance on aerosol generating procedures and BLS in the context of COVID-19, or do you think we won't have any more COVID-19 guidance?
Sorry, I didn't hear well. So I was asking if we were more indication regarding production of aerosol and possibility of infection.
Yeah,
okay.
So will there be more COVID-19 specific BLS guidance?
Well, for the moment, the COVID-19 guidelines have been released a few months ago, so they are still valid. Of course, we need to have to modify slightly the approach to the patients in order to avoid possible contamination by aerosol. So for this, it is important to not perform the not check breathing by opening the airway or looking with your head close to the head of the patients. So you check for cardiac arrest only looking if there is breathing and checking the patient but staying far from the airway. Also, we need to cover the mouth and nose of the victims with a cloth, towel or mask. And chest compression only is suggested for lay people. Then for trained people, of course, the use of PPE and ventilation with the bag mask and possibly with the two-person techniques. But for this, there will be, I think, there will be in the a specific session. Till now, current guidelines are valid. One more thing I want to say is that recently there were also two meta-analyses published on COVID-19. And actually from the studies published till now, none of them reported infections to rescue after CPR maneuvers. So we can continue in this way for the moment.
Fantastic, thank you. And one more question based on the poll. We've asked what people think is the biggest barrier to bystanders starting BLS. And by quite a long way, 49% of people think that fear of causing harm is the biggest barrier to bystander CPR. What do the guidelines say to people about causing harm during BLS?
Also the possibility to cause harm to the patient for CPR has been reviewed with the meta-analysis in with the scoping review in 2020, and actually there is a lack of evidence. What we know is that it is very rare to cause harm to a patient due to CPR. And also, if we perform CPR on a victim that is not in cardiac arrest, it's very rare to produce harm. So performing CPR is safe, both for the victims and for the rescue. And we all should encourage bystander CPR.
Thank you. And I think Teresa will introduce our third and final speaker.
Yes.
Thank
Okay.
you.
So clear message so far is do CPR and do it well, and don't be afraid to do CPR using AED. I think that's what I'm hearing and what the clear signal we're trying to send. So last but not least, we have Mike, and he'll be presenting on emergency medical dispatch. So Mike Smythe is the paramedic and associate professor at the University of Warwick. Please, Mike.
So thanks, Teresa, for the introduction. Good afternoon, everybody. It's my pleasure to be here with you. It's a shame we can't be meeting face to face. However, hopefully next year things will be sufficiently improved to allow that to happen. My disclosures: I am a member of the ERC BLS group, a member of the ILCOR BLS task force, and I receive funding from the National Institute for Health Research here in the UK, where I'm currently working on a study addressing pre-hospital termination of resuscitation decisions. So we know that for patients in shockable rhythms, the likelihood of survival decreases by around 10% for each minute delay to intervention. And minimizing the time to first compression, and where, it's important that we minimize the time to compression and where available, public access defibrillation. And it's essential to improving survival for victims of cardiac arrest. So the emergency medical dispatch centers play a critical role in minimizing that delay to intervention. Essentially, the function of the emergency medical dispatch center is to rapidly confirm the correct location of the emergency, to identify that the patient is in cardiac arrest, and then simultaneously to facilitate telephone CPR with public access defibrillation and coordinate the emergency response to the victim of cardiac arrest. As a consequence of those actions, the emergency medical dispatch center directly addresses the three most important links in the chain of survival. And that's early recognition with early call for help, early CPR, and early defibrillation. The Emergency Medical Dispatch Center also facilitates initiation of that fourth link in the chain of survival by targeting advanced life support providers to victims in need of post-resuscitation care. So as previously stated, the first link in that chain of survival addresses early recognition and early call for help. As a generic reminder, in Europe, the number to contact the emergency services is 112. And the 2021 BLS guidelines have just been released, and these guidelines emphasize that wherever possible, the call to EMS should be made using a hands-free speakerphone mode. Ideally, place the call by the victim's head, and this frees up both hands to perform CPR. Then you simply follow the instructions provided by the call handler. If no mobile phone is available, go and make the call and then return to the victim to start CPR. When your call is connected, the call taker will need to establish the exact location of the emergency. And it can take up to 15 seconds from when the call is connected to the emergency call center to confirm the address. Technology, however, can help us to reduce that interval. Landline systems typically have the ability to automatically pass the address associated with a telephone and to populate the EMS dispatch systems. Secondly, telecommunications giants EE, BT, and HTC developed in the sort of mid-2000s advanced mobile location technology, or AML, that has the ability to automatically pass the location of a mobile phone to within about a 30-meter radius using the mobile phone masts. AML is embedded in both Android and iOS operating systems by default. However, not all countries have this technology turned on, and not all countries exploit the technology. And finally, smartphone applications such as What 3 Words can exploit GPS technology embedded in the smartphone to pinpoint the location within a 3x3 meter grid. Personally, I believe it's only a matter of time before the dispatch center technology routinely supports an invisible handshake between the mobile phone and the emergency call center and automatically uploads the location of the mobile phone. Such technologies will be able to shave valuable seconds off the time required to initiate an ambulance response. So a key task for all call takers is to identify cardiac arrest and to deliver telephone CPR. The ILCOR BLS task force published a diagnostic systematic review in 2019 addressing dispatcher recognition of cardiac arrest. This review noted that cardiac arrest recognition by ambulance call takers ranged from 46 to 98% of cases. Failure to identify cardiac arrest at the time the call is made delay CPR, and can have a significant adverse impact on survival. The most useful verbal descriptors to identify cardiac arrest are that the patient is not responding and either not breathing or not breathing normally. When these two criteria are confirmed, that triggers the dispatcher to provide telephone CPR instructions. However, it's essential that we support call takers to optimize the recognition of cardiac arrest when that initial call for help is received, and emerging technologies, including the use of artificial intelligence and live video feeds, may help us to improve recognition of cardiac arrest. So artificial intelligence technologies combine the use of speech recognition technologies with machine learning. This technology can be embedded into ambulance call center software and can help ambulance call takers to identify cases of cardiac arrest. Blomberg et al. Used audio recordings from 108,000 calls to the ambulance service to train a machine learning algorithm to recognize cases of cardiac arrest. Of 918 cardiac arrest cases within their dataset, ambulance call takers identified 72.4% of cardiac arrest cases, whilst the machine learning algorithm identified 84.1% of cardiac arrest cases. That led the authors to conclude that machine learning may have an important role to play as a decision support tool for use by ambulance call takers. However, we can also exploit the technology available in mobile phones in other ways. So many of you may be familiar with the Good SAM app. Good SAM maps the location of trained volunteers and AEDs relative to a cardiac arrest event, and it dispatches those volunteers to initiate earlier life support. However, Good SAM technology is capable of significantly more. Good SAM can be embedded into the emergency dispatch center and allows the dispatcher to send a text to the caller's mobile phone. If the caller accepts that text, the control room will then be updated with the location to within a 10-meter radius. It also allows the control room to view the scene via the camera of the caller's smartphone, and it can do this without the Good SAM app being installed on the caller's mobile phone. We already know that EMS systems that provide telephone CPR instruction have better outcomes compared to those EMS systems without telephone instruction. But what would happen if the dispatcher could actually see what was happening using the technology that I just described? This functionality would allow the dispatcher to visually confirm the condition of the patient and to provide more specific instruction to the caller whilst performing CPR. Earlier this year, the ILCOR BLS Task Force completed a systematic review that will be published in the upcoming Consensus for Science and Treatment Recommendations document that addresses the impact of video-based dispatch systems. The review identified one clinical study by Lee et al. Enrolling over 1,700 patients. The unadjusted odds ratio suggested that there was a significant benefit for video-based dispatch versus audio-based dispatch, with an odds ratio of 1.73, so almost 75% more effective, and the 95% confidence interval spread between 1.16 and 2.59. However, when adjusting using propensity score matching, so looking for similarities between patients, the adjusted odds ratio did not show a benefit. So there it was 0.85 and the 95% confidence interval stretching from 0.52 to 1.4. That systematic review further identified 13 mannequin studies that suggested that video-based dispatch reduced the time to first compression and led to improved compression rates. However, video-based dispatch showed no benefit with respect to hand position, compression depth, release, or time to defibrillation. As this technology improves and more research is published, we will be in a better place to understand the potential benefit of video-based dispatch systems. And finally, modern EMS systems utilize GPS to automatically identify the nearest available ambulance resource. This is commonly a background function and that doesn't require any input from the dispatcher. However, the system also facilitates a redirection of ambulance resources away from lower priority calls to the cardiac arrest event, if they are closer to the victim of cardiac arrest than the unassigned resource. However, the system automatically plots the location of ambulance resources, but the dispatcher must reassign the closer ambulance to the cardiac arrest case. In addition to that, we have the software such as Good Sound that I mentioned previously that can be embedded into control rooms to automatically activate community first responders within a defined radius of the cardiac arrest event. And it also maps the locations of nearby AEDs to facilitate bystander use of AEDs before the arrival of EMS when there's more than one responder on scene. So to summarize then, the Emergency Dispatch Centre plays a pivotal role in the first 3 links of the chain of survival. Technology is helping us to reduce the time required to accurately obtain location details. GPS is helping us to improve resource allocation to the highest priority cases. And artificial intelligence may well support call takers to identify cases of cardiac arrest. And finally, smartphone capability may assist emergency medical dispatch systems to recognize cardiac arrest, to improve the delivery of telephone CPR, and to facilitate public access defibrillation. Thanks very much.
Thank you, Mike. So I'll turn over to James in a second, but I just wanted to ask you really quickly. So you now showed us sort of 2 exciting new avenues for dispatch. One is using video communication and the other is AI. Although from what you just showed us, the AI recognizes 84% of cardiac arrests. Now, arguably, a lot of systems would actually outperform that AI. And then you look at video and then trying to compare, apples to apples and not apples to oranges. It doesn't, the one study we had didn't really convincingly improve outcomes. So, what do you think is the most promising, AI or video, or do you think it's going to be something completely different to improve dispatch?
So my gut feeling is that the next sort of big improvement from the EMS dispatch side of things is probably going to be technology related rather than further exploration of keywords. Whether or not that comes down to AI or video-based dispatch, I'm not entirely sure. I think you have to recognize that both of those have an opportunity cost in terms of the investment that it requires. And I think at present, we really don't have enough information to make a sort of a real strong and robust decision about whether or not to implement these things. As you kind of pointed out, there's the systematic review that the ILCOR BLS task force conducted about dispatcher recognition showed rates from the 40s to 98%. And that's really, really high. And when we look at sort of the AI versus dispatcher, that's 72 versus 84%. In that context, the AI is going to underperform the dispatcher, some of the dispatch centers. So it may not be worth investing in the technology in those areas. Where you've got underperforming or sort of areas that are struggling to recognize, then AI may be beneficial to assist the call takers, but it has to be borne in mind the cost of implementing that. And I think when it comes to video instruction, there's clearly going to be a delay establishing that video link. So, and we don't quite know what the opportunity cost that's going to be. It's suggested from the mannequin studies that it leads to a shorter time to first compression, which in theory should be a good thing. But in the single study that we have looking at clinical outcomes, that's actually not borne out in the data. So I think at the moment, both of those technologies are probably best reserved for the research context until we have more data. And when we have more data, we can make a better judgment as to whether or not they should be for widespread implementation.
Thank you, Mike. So certainly encouraging people to do more research and encouraging people that are already using these technologies to publish their experiences so all of us can learn.
Yeah, absolutely. So I think where systems already have these things embedded, it's really important that they monitor and that they publish their findings. But for systems that don't yet have them embedded, it's probably too early to say invest in these technologies.
Thank you. Okay, James, you have questions lined up?
Yeah, so lots of questions coming through, and you've touched brilliantly on the poll that's just gone about asking people how they feel, how they would feel as a bystander about the dispatch centre accessing their video camera. Mike, you've obviously just touched on the challenges of implementing video from a dispatch center side, but from the bystanders perspective, what challenges are there to implementing video?
So I think, to be perfectly honest, I think a lot of the stuff is like the same sort of challenges that you'd have with day-to-day stuff. So people do video calling, be it by FaceTime or WhatsApp and those sort of things. And obviously the quality of the signal has a bearing on how well that call works. So I think those same sort of technology limitations are going to apply in the context of a video-based dispatch system or calls from the control center to scene. I don't think it's yet clear if there are any sort of privacy issues that could be at stake. So I mentioned earlier with the AML systems that not all countries have implemented sort of AML or are taking advantage of the AML technologies. And part of that may be related to privacy. Certainly, I know that with the Good SAM app, they indicate that when they access your phone, they keep no data, there's no recording, and that certainly it's a one-time use and that there'll be no consequences. But whether or not that continues with other platforms, I don't yet know. So there may well be a sort of a privacy security issue that as yet remains to be adequately addressed. But I think realistically, the limitation of technology probably comes down to the limitation of the connection and the bandwidth of that connection to pass the video signal.
Thanks, Mike. Staying with technology, you talked about the use of apps to locate AEDs. Somebody has asked, with these apps becoming very accessible, is there a risk that there's a delay in calling EMS because people use the app to find an AED?
I suppose that's a really good question. I suppose to a certain extent, if somebody was delaying the call to fetch an AED, they probably had a good understanding of the chain of survival and were making a value-based decision that they could defibrillate a patient prior or at a sooner time point. I suppose there is a very real risk that if the AED is some distance away or there are challenges getting access to the AED where it may be locked in an office or something like that, that delays the time, then doing that in preference to making the call is probably suboptimal. There's no reason why, if we've got sort of mobile phone technology now, that somebody can't start CPR. If there are other bystanders, send them to fetch the AED, or hopefully if it's something like Good SAM app and multiple responders are dispatched to the scene, then one of them will bring with them an AED.
Thank you. So there's lots of questions still about language. So how to describe where rescuers should place their hands on the chest. So should we say opposite the axilla? Should we say the center of the chest? Should we say the lower part of the sternum? I know it's not specifically what your talk was on, but can you comment on what we should say when we're teaching people about where to put their hands?
So I think we need to be consistent with what the guidelines say. It's important for us to have a consistent message. So lower half of the sternum. Essentially what we want to be trying to do is make sure that the hand is compressing roughly over the area of the heart. And I think that's probably the way that we should go in terms of position. Certainly the video dispatch evidence, or rather the studies addressing video dispatch, show that actually having the video function didn't make an impact on correct hand position.
And we've got our other speakers here now. So of the questions that we've got remaining, we'll open them up to everyone to discuss. So a really popular question that's not been covered is, how would you recommend teaching the correct hand position for prone patients? Does anybody want to have a stab at that?
I think we should let an intensivist have a go at that.
Artem, you're an intensivist.
I don't think there is any not much evidence on this, but it is covered in the COVID-19 guidelines, I think. I'm not sure because I've seen it somewhere definitely, but there is not much evidence on the correct hand position in prone patient, but chest compressions in prone position are definitely effective, and it is clinically applicable. And as I remember, the correct hand position should be between the two scapular bones on the spine bone. Yes, that's the correct It's a language issue for me now. If it is any additional data on it, I'm not sure really if any colleagues will assist me in answering this question.
Oh, I think I don't know if it can be answered any better than that, Achtam. There is an upcoming systematic review from ILCOR on prone positioning, really looking to see, you know, what do we have in terms of evidence, and obviously there's not a lot. You know, there's some experiences from sort of the previous RDS populations, and obviously if you have a hypoxic cardiac arrest and you're so sick that you're in the ICU and you're prone, then you know you're in a pretty serious situation if you get a cardiac arrest. But as you say, chest compressions can be done in the prone position. You know, there is, we do believe that it would move blood flow forward. And it's, again, it's balancing the risk of trying to turn someone around to do standard CPR or leaving them in that position for some time.
There's one.
I don't know, Giuseppe, you wanted to chime in as well?
I just want to recognize that CPR in the prone position will be only a kind of a temporary bridge, because if the patient we don't get ROSC, then we need to move in the supine position right away. So I think that for such a small period, you do the best you can in the prone position.
It's a bit of a nasty question, isn't it? Have any more good ones, James?
So somebody has asked, does the ERC consider a do not resuscitate tattoo as a valid reason for bystanders not to start resuscitation? Because I think this is probably a common question for instructors when they do courses. Who's going to have a go at that one?
Well, I not the correct question to answer, because in Italy we still have a lot of problems also with the formal documentation. So, for example, for sure in Italy a tattoo is not valid, but I don't know in the other states.
In our country, we don't have any legal background for do not resuscitation, so the tattoo will definitely be not an issue if we talk legally, definitely.
And Mike?
I would suggest that from the UK perspective, there's certainly discussion in the journals about the sort of the hypothetical validity of those, but by and large, they don't sort of hold any legal basis, and we tend to resuscitate when there's a tattoo. Not that I've ever encountered it, but my default position would be to resuscitate.
Brilliant, thank you. And have we got time for one quick extra question, Teresa?
One last one, go ahead.
Which is quite commonly the lateral pad isn't placed suitably deep into the axilla. So have you got any advice on teaching that and getting people to put the pads in the right place?
That has your name on it, Giuseppe.
Sorry.
Any advice?
No, because there's some
in the right place.
Sorry, could you repeat, because I have some background on the.
Do you have any advice to make sure that bystanders place the pads of an AED in the correct?
Yes, sorry. The anterolateral position, the standard one, is just the recommended one, but the best way for bystander is to look at either the AEDs or the surface of the pads, because there you can see the picture or how to place the pads. So can just refer to the picture on the device or on the pads,
rather than people having to try and remember it. Good answer, thank you.
Yeah. So answers it. Check the instructions manual. But, okay, I think we're just about out of time. On behalf of James and myself, thank you so much, Giuseppe, Mike, and Achtam, for excellent talks on BLS. There's about 30 minutes before we have an ALS session, so please go grab some more coffee, maybe have a quick dinner, and please be back for 6 o'clock when we have the ALS session. So thank you so much for tuning in.
Thank you.
Bye-bye.
Bye-bye. Thank you.